All right, so we are at 7 o'clock. I think we should go ahead and start as people are trickling in. My name is Pa Vang, and I am the mission chair for the liberal arts at St. Catherine University. Welcome to everyone to the St. Catherine University Integrated Learning Series of Summer 2020 at the confluence of the liberal arts and social justice, Race in the Machine. This series is hosted by the Dean's Office, Dean Tarsha Stanley, and Associate Dean Jeff Johnson, in partnership with the Community Response Team. The Integrated Learning Series, Integrated Learning at St. Catherine University, is a multidimensional expression of an active liberal arts pedagogy. Located at the intersection of creative energy and critical reflection, the Integrated Learning Series is one way we partner academics with activism, the paper with the performance, and the campus with the community. It is the array of courses, activities, speakers, events, performances, and exhibitions that coalesce into our ways of knowing. The Integrated Learning Series is the web that binds our learning experiences together and the narratives that connect our collective community. Tonight, our program is titled COVID-19, Unmasking Health Inequities. Our presenters for tonight are Fardowsa Mohamed and Tara Rick, as well as 4 student panelists from the PA program who will introduce themselves during the panel discussion. About our session tonight, the COVID-19 pandemic has significantly affected communities all over the world, caused by a novel SARS-CoV-2 virus. If all Minnesotans are at risk for this novel virus, why are minority populations disproportionately affected? Specifically, why do Black Minnesotans account for 37% of COVID cases when accounting for less than 7% of the total Minnesota population? And why is mortality 8-fold higher than White Minnesotans? This lecture examines the factors leading to COVID-related health disparities by examining the effects of structural racism on our minority populations. We will examine how the COVID-19 response is perpetuating health inequity. Lastly, we will discuss our role in addressing inequality as healthcare providers in ways we can help ameliorate these disparities in our communities. About our 2 speakers today, and our 4 students will introduce themselves. First, we have Fardowsa Mohamed, who is an alumna of the St. Catherine University PA program. She has been a hospitalist PA at Mayo Clinic in Rochester, Minnesota since 2018. She has a background in public health and is interested in racial and socioeconomic inequities as they pertain to healthcare. Tara Rick has been a physician assistant in hematology and oncology, working at mHealth since 2006. She is an adjunct faculty at St. Catherine University Master of the PA Studies program with a focus on oncology, global health, and co-founder of the Global Health and Underserved Populations track. Tara is particularly interested in global oncology and sits on the board of the Foundation for Cancer Care in Tanzania, an NGO that supports a new cancer program in northern Tanzania. Currently, Tara is a PhD candidate at Erasmus University in the Netherlands and splits her time between the US and the Netherlands, Ethiopia, and Tanzania. I will now hand it off to Tara to moderate our session tonight. Tara?
Thank you, Dr. Vang, for the introduction. Oh, I'm getting some feedback. But are you guys having problems with feedback? Or can you hear anything?
I can hear fine.
Okay, great. So I also want to thank Dean Stanley and Associate Dean Johnson for the opportunity to discuss this topic with the greater St. Catherine's community. This lecture will be broken into thirds, a little bit different than some of the other lectures in the lecture series. First, you'll hear from Fardowsa as she examines the factors leading to COVID-related health inequality and how the COVID-19 response is perpetuating this issue. Then we'll have you'll hear from our student panelists, which we will introduce later. And together we will all discuss the role of healthcare providers in this system and what are the next steps moving forward. And then finally, we'll open the remaining time for a Q&A with the audience. We want to hear from all of you, and we want to thank you for joining us tonight. And now I'd like to turn it over to Fardowsa.
Thank you so much for inviting me to give this talk. Again, as Dr. Banks said, my name is Fardowsa. I'm a physician assistant at Mayo Clinic. For this talk, I want to discuss COVID-19, but more importantly, the structural racism that has really worsened outcomes for our communities of color. So the first thing I want to do is I want to begin by laying out the objectives for this talk and what I hope we can gain from it. We'll first begin by discussing the data on COVID-19, particularly in Minnesota, and how this virus has disproportionately affected communities of color. Then we'll discuss in general, the various social determinants of health, and then in more detail, discuss the structural racism that has worsened COVID-19 outcomes for our communities of color. And we'll discuss in detail diet and nutrition, employment, housing, access and quality of care, and how implicit bias plays a role in this, and research and mistrust. Then I hope we can discuss how we can move forward from this pandemic with a tool set of knowledge, skills, and experiences that will allow us to combat social determinants of health and the structural racism and act as catalysts for change. So if you look at the COVID-19 data put out by the Minnesota Department of Health that focuses on race and ethnicity, we see that Black Minnesotans are testing positive for COVID-19 at more than 6 times the rate of their white counterparts. Latino Minnesotans are testing positive about 8 times the rate of white Minnesotans. And both of those groups, Black and Latino individuals, have the highest age-adjusted rates of hospitalization from COVID-19. And if you look at Indigenous and Black individuals, they have the highest age-adjusted rates for COVID-19 deaths, about more than 100 deaths per 100,000 residents. And what I want to note here is that oftentimes we hear how COVID-19 is killing communities of color. But yes, and that's the case, but I think it's important from a language perspective that we really highlight that what's causing this disproportionate effect is our structural racism, and that's what's worsening it. So we have these rates, but again, it's our underlying structural racism that is worsening that. And I know some of us tend to prefer pictures and graphs. I've included that from the website of Minnesota Department of Health. So this first one looks at the positive cases in Minnesota, particularly the case incidence per 100,000 residents. And it looks at the COVID-19 cases and it breaks it down by the different races. And if you just take a look briefly, you'll see, early on, just the stark differences of how it affects primarily communities of color when compared to our white Minnesotans. Now, if you look at the percent of positive cases in the ICU, again, we see that, again, our communities of color are more affected, again, when compared to white Minnesotans. It's not that white Minnesotans are not testing positive for COVID-19, they are, but they are not being hospitalized at the same rates as communities of color, and they're certainly not being admitted to the ICU at the same rates as well. And if you look at the death incidence per 100,000 residents in Minnesota, again, you'll see our communities of color are more significantly impacted when compared to white Minnesotans. And our Indigenous population here tends to be the most significantly affected negatively as well. So let's start by defining what the social determinants of health are. And what they are conditions in an environment where a person is born, lives, works, that really affect a wide range of their health. And they don't just affect the length of life, but it also affects quality of life as well. I want us to take a second to look at this graphic on the left-hand side. If you take a look up here in the left upper hand corner, you'll see health outcomes, and our health outcomes are influenced by two things: policies and programs that have been put in place by our government, but also different health factors. And health factors are broken down into, health behaviors, clinical care, social and economic factors, physical environment, and that's broken down even further. And these all influence health outcomes, specifically our length of life and quality of life. And I want us to discuss in more detail, like I said, diet and nutrition, employment, housing, access and quality of care, implicit bias. So we know that we have all of these different environmental and socioeconomic factors that influence our health, but how does this relate to COVID-19 outcomes? So if you have, poor nutrition, poor diet, you live in an environment where you have not the best air quality, you don't have good housing, and not appropriate transit to get you to a clinic to be seen by a provider, a poor education, on and on, et cetera, et cetera. All of these things can influence, becoming obese, leading to chronic diseases such as, hypertension, diabetes, heart conditions, and also lung conditions. And also, all of those things can lead to severe outcomes from COVID-19. If you look at this graphic, you'll see it's pretty much a vicious cycle where these social determinants of health not only can lead to obesity, can lead to chronic diseases, but also obesity itself can lead to chronic diseases. And all of these influence what the outcomes of your COVID-19 infection may end up being. So the first social determinant of health we'll focus on is diet and nutrition. So what constitutes a nutritious diet? Well, according to the World Health Organization, a well-balanced diet includes green leafy vegetables, lean meats, whole grains, fruits, and emphasizes avoiding salt, too much salt, trans fats, and added sugars. But the reality is there are disparities in nutrition that are influenced by socioeconomic, educational, and environmental factors, meaning, not everyone is able to afford healthy foods. Not everyone is able to have the knowledge or skill set to read a nutrition label. And then there are some people who just don't live in an area where they have access to healthy food options. According to data put out by the United States Department of Agriculture, Hispanic and Black households are actually twice as likely to be affected by food insecurity as compared to white households. So even if you account for the differences in social and economic factors, there's still evidence to suggest that there's still a higher risk of food insecurity among people of color. And it's interesting because the United States has actually been researching food insecurity for many, many decades. And so the percentage of food insecurity among households has actually risen and fallen over a number of years. But what has remained about the same is that gap in prevalence between Blacks and whites in America. So if you look at this graphic, you'll see it looks at the trends in food insecurity over the years, looking at race and ethnicity. On the x-axis, we have the years, and on the y-axis, we have the percentage of households affected. And the lines look at the different households separated by race and ethnicity, purple being white, and then all the way at the top, orange being Hispanic, and then blue representing Black households. You can see just at a quick glance just how large the gap is. And even though this has kind of risen and fallen over the years, that gap has really never closed or even shrunk significantly. Then we also have food deserts that influence diet and nutrition. And food deserts, as defined by the United States government, are areas where people have limited access to a variety of healthy foods. Studies have shown that only about 8% of African Americans live in a census tract with a supermarket as compared to about 31% of whites. It's interesting because there was a recent study done by researchers at the Johns Hopkins School of Public Health where they found that particularly in Baltimore and predominantly Black low-income neighborhoods, they were 8 times more likely to have carry-out liquor stores than white or racially integrated neighborhoods. And it's unfortunate because there are a lot of factors that influence individual health behaviors, but when you're being offered more alcohol and you're being offered healthy food options, that definitely plays a primary role in that as well. And so this graphic is interesting because it looks at the relative access to grocers and fast food in Chicago by race, by block. And you can see it separates the groups by their races. And everyone relatively has the same access in terms of distance to fast food options and grocery stores. But if you look at the second line representing African Americans, it's much more easy for them to access fast food restaurants as opposed to grocery stores. So we know that poor nutrition puts you at an increased risk of developing obesity. And we have to understand how obesity is defined and how it, unrelated to COVID, affects the body. And to determine if someone is obese, we use a measurement called the BMI, which is a body mass index, which is derived from the mass and height of a person. And a BMI greater than or equal to 30 is what's defined as being obese. And for reference purposes, a normal BMI is between 18.5 and 24.9. I just do want to throw out the caveat that these are just general numbers. There's always going to be outliers where people may have, greater muscle mass that may skew some of those numbers, but these are the numbers that are generally used. So obesity itself actually causes changes in a person's immune system, where it can really either impair the immune system or kind of put it into this overactive drive, which leads to dysfunctional cytokine production. And cytokines are important in the immune system because what they do is they are cell signaling molecules that aid in cell-to-cell communication and immune responses and stimulate the movement of cells towards sites of inflammation, trauma, and infection. And in obesity, you have this chronic state of inflammation that can lead to a cytokine storm where the body or the immune system overreacts and kind of goes into this overdrive and sends all of these cells to not only an area where there's an infection, but it can also send all of these cells to areas or organs that are completely healthy. And that's a cytokine storm is actually a characteristic of a severe COVID-19 infection. So just to help kind of put an image in your head, this is a CT, these are both CT scans of chest or lungs. The first one on the left is a normal scan of a healthy lungs, looking at just the pulmonary vasculature. You can see there normally. And on the right-hand side, you'll see someone with a severe COVID-19 infection. And in this one, you can see what radiologists describe as more ground mass opacities. I don't know if many of you have heard that term being thrown around, but it describes kind of more of the relative inflammation in the lungs in a COVID-19 infection. The second social determinant of health that we'll focus on is employment and the difficulties of that during the social distancing. From the beginning of this pandemic, we were all encouraged to social distance, wear masks, and stay home from essential work. But what if your work is deemed essential? What happens to you in that case? According to the American Journal of Industrial Medicine, people of color tend to be employed in essential industries, and obviously this puts them at an increased risk of developing COVID-19. So I have this list here. I'm not going to go through it, and it's not exhaustive, but these are some of the occupations that are considered essential. Obviously, the media tends to focus primarily on healthcare being the frontline workers, but there are a lot of other people who fall into this category as well. Now we'll talk about relationship between race and essential work. There's actually a recent study put out by the Boston Public Health Commission that looked at Boston neighborhoods, and it found that most of the neighborhoods that were affected the most by COVID-19 were co-located with the highest proportions of essential workers in the city. And then there was a recent study in San Francisco that showed that while Black workers accounted for about 5% of the workforce in their city, they accounted for about 23% of public transit workers, which is classified as an essential job. And Latino workers, who made up about 22% of the workforce in San Francisco, made up about 67% of workers in building, cleaning, and waste. Again, these are all occupations that put you at an increased risk of developing or contracting COVID-19. So this graphic right here looks again at that study that the Boston Public Health Commission looked at, where they looked at the different Boston neighborhoods. And so this one on the left looks at the percent of workers in the COVID-19 essential positions. So the darker shade of red represents more people who have essential jobs during the COVID-19 pandemic and where they live. And on the right-hand side, it looks at the rates of COVID-19 positive cases, and you can see the overlap quite nicely. The second one looks at now the percent of non-white residents in these Boston neighborhoods. And again, the darker shade means a greater percentage of non-white residents. And again, on the right, we have the percent of COVID-19 positive cases in those Boston neighborhoods. And again, there's overlap. So we have kind of these overlapping this layering effect that we have, where you have communities of color who already have these social determinants of health that worsen patient outcomes for them with COVID-19, but also they do these essential work or have essential occupations that also increase their risk of contracting COVID-19. So another social determinant of health is housing, and then we'll talk more about overcrowding. There are many ways to define overcrowding, but in this particular case, we'll define it as more than one occupant per room in a household. Overcrowding, when they studied it in New York in specific neighborhoods, they found were more common among renters and homeowners, 13.4% as compared to about 4%. And we know that, as the economy has been struggling, there is a shortage of affordable housing, and this has led to a lot of people cohabiting just to save money. And we know that people who live in, tight, overcrowded spaces are at a higher risk of contracting communicable diseases such as COVID-19. But I think it's also important to remember that it's not just that leads to overcrowding. We do have different cultural differences, specifically between different communities. So if you look at the typical white American household, we have the nuclear family that's made up of the parents and the children, and they just live in the household. And if you compare it to other communities, it's not uncommon to have extended families living under one roof with the parents, the children, the aunts, uncles, grandparents, etc. And so in New York, they found that about 18.4% of Latino households were defined as overcrowded, as compared to 2.4% of white households in New York. And then for access and quality of care, we have implicit bias, and then we'll talk about our response to COVID-19. So implicit bias itself is defined as attitudes and stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So if we talk about COVID-19, we look at symptoms, and symptoms themselves are pretty subjective. But the three symptoms that we pay attention to are cough, fever, shortness of breath. And we know that if there's a delay in diagnosis and a delay in treatment, there is certainly going to be poor patient outcomes. And then there's also, research and the history of research in this country that's led to mistrust. And then, currently as it stands, the COVID-19 clinical trials. We know that there's a history of unethical research on people of color in this country that has really led to a mistrust of the medical system, going from either, the Tuskegee trial, the syphilis study, an NIH-funded study on Guatemalans intentionally giving them STDs, and also the father of modern-day OBGYN research, who tested his studies on enslaved Black women without anesthesia. And you can see how all of that history in this country has influenced people of color to not be so accepting of research, accepting of being in clinical trials, and that poses to be quite a big issue for the COVID-19 trials. So even as, if we look even before COVID-19, there was an underrepresentation of people of color in clinical trials, where Black Americans make up about 5% of participants, in clinical trials, and they account for about 13% of the country's population. So we know that in order for any vaccine, particularly the COVID-19 vaccine, to be effective, we need to have a very diverse pool of participants so we can better understand the effectiveness and the efficacy of this vaccine. So I want to, move on to the panel portion of this and talk about, how we can combat implicit bias and structural racism and what we can do as, providers, students, community members to use what we've learned from this pandemic to help our patients, help our neighbors and friends, and act as, people who have learned from this pandemic.